Good morning, everybody. Today we are going to have a wonderful session by two eminent dermatologists from South and North. This is about a very important topic, the atopic dermatitis. Atopic dermatitis, as you know, is a very common, and when you are going to practice after your MD, there will be a lot of challenges that can be faced by you in atopic dermatitis. But in order to prepare you for the exam, as well as in order to prepare your future, we are planning to have atopic dermatitis webinar, and it will be covered in 3 or 4 sessions. One is, as you all know, one is the definition and Etiopathogenesis, and the second today is clinical features. Both these topics will be covered by eminent dermatologists who are having special interest in atopic dermatitis. I'm sure all of you have heard about Dr. Ramamurthy and Dr. Ram. Dr. Ramamurthy is a very learned man, academician, and of course he is a very good practitioner. He had a lot of experience in atopic dermatitis, and he will be giving the first talk on the definition and Etiopathogenesis. And in hearing him, you can gain a lot of insight into the definition and Etiopathogenesis. We all skip the area of Etiopathogenesis, but it is important for you to understand atopic dermatitis. A clear idea of Etiopathogenesis is very, very important. So, with this, a few words of introduction, I invite Ramamurthy to go ahead. Dr. Ramamurthy.
Thank you, sir. Thank you, sir, for the nice introduction. I think it is a pleasure to be part of this program, and I do hope that this will help our postgraduates to build up their knowledge on a sound basis. And as you said, this is a very rare topic. We seldom discuss this atopic dermatitis. This is a topic which is we very rarely do we discuss this topic in our either in our forum. I mean, in conferences as well as in colleges also. And I'm happy that you have given me 30 minutes of time. So I think that will be sufficient enough to elaborate this topic. Am I audible? Hello, am I audible?
Yes, doctor. Yes, doctor, audible.
Okay. Actually, the title given to me was Etiopathogenesis and definition. I don't know, it's very, very difficult to define atopic dermatitis. We all generally use, we recognize atopic dermatitis in practice by instinct. I mean, by repeated practice, we diagnose it in most of them. Only in atypical cases, we have difficulty, we resort to the criteria. I think Ram Gulati will elaborate more on that. I would spend more time on the etiopathogenesis, and I think since there is no universally accepted definition of atopic dermatitis, I think this highlight on etiopathogenesis will give you enough material to think and understand atopic dermatitis. So the very first the starting point for discussing about atopic dermatitis should be this the age in which it is prevalent. Most of us use this study, which was published in 2004, about the incidence of prevalence of atopic dermatitis, and it is mentioned that most of the 98% of atopic dermatitis occurs in childhood, but it's not true. If you look into the study, this study was done in children less than 7 years of age. So in children less than 7 years of age, 60% of atopic dermatitis develops within the first year, and most of the AD develops between 3rd and 6th month of life. So I mean, this point will help us to know that there is something must be occurring in a newborn or in early life that should make a person susceptible to or vulnerable to atopic dermatitis. Let us look at the common sites. The second thing that we have to know is what are all the common sites. If you carefully look at it, face, post-auricular region, popliteal fossa, flexural area, and also extensor in infant. Infant extensor is more common. In older children, flexors are more common. And in older age group, as in older children, the morphology changes. So you have got a age-specific morphology and age-specific distribution also. That is the characteristic clinical feature of atopic dermatitis, and there is a pathophysiological basis for the development of these features. So I told you 2 things you have to remember. Why it is more common in infants, 3 to 6 months of age? Why is it that 60% of them develop atopic dermatitis within 1 year? This we were talking only about children. Okay. Why is it that these certain areas are very commonly involved in atopic dermatitis? The clue is the stratum corneum. Unless we study the stratum corneum, we will not be able to understand atopic dermatitis. Stratum corneum is thinner, 30% children in a newborn, and the corneocytes are at least 1/5, 20% smaller. Not only that, so this makes them more vulnerable to the disease, which is basically an epidermal barrier dysfunction. Atopic dermatitis is a disease due to interaction of epidermal barrier, dysfunctional epidermal barrier, and immune dysregulation. These are the 2 themes which we again and again talk about it. So a paradigm shift occurred in 2006 or more after a genetic mutation in a gene called Filaggrin was discovered, and after that there was more emphasis on the epidermal barrier dysfunction. And now recently, with the new biologicals which we have got to target atopic dermatitis, the focus, the pendulum has swung in the direction of immunodysregulation. So it's not only that the stratum corneum is thin in a newborn, also that in every person, face and flexures have got a thinner stratum corneum. So these 2 reasons make atopic dermatitis common in the face and the flexures. This is the brick and mortar model proposed by Elias. There are 2 components. This stratum corneum has got a plasma membrane which is replaced, and it does not have a plasma membrane like the rest of cells. It contains a thick shell called as cornified envelope. And in between the cells, it is packed with the lipids. The lipids are very unique. In the rest of the body, ceramides will be less than, and most of them will be phospholipids. Ceramides will be less than 10%, if at all they are present. But the skin, ceramide is 30 to 40% of the weight on weight basis. And that is the commonest lipid, not like phospholipid and cholesterol, which is seen in the rest of the plasma membranes. I mean, in the rest of the body. In skin, it is ceramide is the major component, and fatty acids and cholesterol. That is the intercellular membrane, and the cell is full of natural moisturizing factor. This I am talking about corneal side, in which you have got which to retain the water and surrounded by a thick shell, a proteinaceous cell. It's a better representation by Cork. He proposed this model in 2009. You have got 3 components. You have got 4 components: natural moisturizing factors, and then a cornified envelope, cornified cellular envelope, proteinaceous cell, then intercellular lipids. Not only that, these bricks and mortar, they are all much more reinforced by rivets. which are nothing like bolt-like things which connect the corneocytes. So there are 4 components. Now it is called as air-liquid interface. It is very important to know the stratum corneum. Second thing that is important to know about to understand etiopathogenesis of atopic dermatitis is the tight junction. Tight junctions are within the stratum granulosum. Stratum granulosum has got 3 layers. Stratum spinosum has got 10 layers. In stratum spinosum, we have got Langerhans cells. So you can see the Langerhans cells here. In stratum granulosum, there are 3 layers. Uppermost is stratum corneum, stratum granulosum 1, then stratum granulosum 2, and the stratum granulosum 3. And these unique tight junctions, they are designed to maintain polarity between the apical and lateral surfaces. So in the second layer of stratum corneum, stratum granulosum, SG2, you have got this tight junction. These tight junctions are situated at the apical lateral border junction. So you can see the tight junction. So this is a liquid-liquid interface. Earlier we talked about air-liquid interface. This is liquid-liquid interface. This prevents egress of, the inside of the body is protected from the outside. And in fact, whenever that tight junctions are damaged, these Langerhans cells will cross this tight junction and peep through, which is like a window, and get access to the antigens which are outside the tight junction. In fact, nerve fibers never cross the tight junctions in a normal healthy person. As we later on, I will elaborate, it crosses the tight junctions in atopic dermatitis. Okay, these 2 structures are very crucial in our understanding of we should understand them in depth. So you can look at the Langerhans cells, which are deeper. Now these dendrites can cross these tight junctions whenever there is a damage to the tight junction. It can even seal the tight junctions also. So and they react to the surroundings. Either now it is thought that Langerhans cells most often promote tolerance to the external antigens, whereas this is not happening in atopic dermatitis, where they induce immune activation rather than tolerance. This is a small slide about how the skin barrier development takes place. You know very well that sebum is very high at birth, and hydration level is also picks up after birth. But after 6 months, the sebum levels are not perceptible, and that is why in the 3 to 6 months period. So the child is prone to atopic dermatitis. And stratum corneum thickness and transepidermal water loss takes place 3 to 4 years of life. Please remember this. Atopic dermatitis occurs more common in the cities because the skin barrier does not develop maturity. It does not attain its full competency in the city life. And when a child is placed in a densely populated place, or when it is not protected from, it is away from natural surroundings, this development of epidermal barrier is very much delayed. That is why probably we see more and more of atopic dermatitis in more crowded localities rather than in less in towns or villages. So this is a very valid important issue. It takes 3 to 4 years for the skin barrier to develop in a child. So there are 4 components in the skin barrier. I have already told you. There is tight junctions come under physical component. Acid mantle comes under the chemical component. Then you have got a microbiome. We will talk about it later. Microbiome is the most common topic discussed these days. There are 2 views of atopic dermatitis. One view is it is an epidermal barrier defect primarily, and secondarily immune dysregulation. Or other one is immunological dysregulation is the primary issue, and subsequently the epidermal barrier defect is a manifestation secondary to immunological dysregulation. We will expound these 2 issues, these 2 views in our lateral slides. The reason why this outside, that is outside inside hypothesis was proposed by Elias and Steenhoff. They have noticed a barrier abnormality even for 5 years after clinical resolution in children or adults who had atopic dermatitis. So they proposed that some inherent occurred insults should be the primary driver of disease activity. And we have got lot of mutations after Filaggrin which have been reported, such as Hornerin. In fact, in Africans, Filaggrin 2 is reported, and proline, the small proline-rich protein 3, and then claudin. Claudin is the tight junction protein, and almost 30 loci have been linked to atopic dermatitis by genome-wide scans. And because the problem here is different genes influence the disease in different ethnicities. Only some genes are common. For example, Filaggrin, interleukin 13, and OL N1 is another 3 pro genes which are all seen in, which are not dependent upon any ethnicity. It is seen in reported worldwide and consistently repeated. Most of the other genetic mutations have not been reported to occur in all the communities studied. A word about Filaggrin. Filaggrin is a very important protein. This Filaggrin, it is essential for the aggregation of the cytoskeletal the keratin filaments and ordering and bundling up with this keratin filament. That is why stratum corneum it becomes flat. If you look at this photograph, you can see that how stratum corneum is flat here. So this flattened cells is created only by the Filaggrin. Subsequently, it breaks down in the stratum corneum to produce products which acidify the stratum corneum and natural moisturizing factors. In fact, we are not very sure how much this acidification is contribute to the acid mantle of the skin pH, because acid mantle can be due to Filaggrin products, it can be due to fatty acids from sebaceous glands also, it can be due to sodium hydrogen antiporter, it can be also due to melanocytes. But this Filaggrin mutation is not seen in around 40% of, even in the most highly prevalent area like Northern Europe. It is not seen in 40% of patients who have atopic dermatitis. So there, the basis is the Filaggrin movements retracts the cytoskeletones. That is that. So the lipid delivery into lamellar bodies. These lamellar bodies are essential for the depositing the lipids in the intercellular space, which I had already shown you. So this lamellar body's delivery is impeded, and lamellar body's stem cells cannot accumulate lipids. So Filaggrin deficiency causes lipid delivery is disturbed, and mainly increasing, it contributes to increasing pH. The increasing pH increases the activation of certain enzymes in the skin which work best at an alkaline pH. Normal pH is neutral at birth. So when pH is very high, the problem is the high pH causes breakdown of the structure called corneodesmosome. I told you it's called a rivet. Which it is a component of the rivets in the model proposed by Cork. So corneodesmosomes are destroyed or broken down. So the problem is the stratum corneum does not develop into a multiple layer. It normally at least 10 to 20 layers it will be there. As it goes up, it will have more and more quota of natural moisturizing factors. It will become more and more thick also. The corneoid cellular also will become thick. But because of this premature breakdown of stratum corneum, the cell wall is not thick, and intercellular lipids are also not deposited, and it cannot accumulate enough natural moisturizing factors. So a thinner stratum corneum means a dysfunctional stratum corneum. That is why in face there are only 10 layers. That of stratum corneum in the face. That is why the face is very much susceptible to epidermal barrier damage. So that is the basis for the for proposing epidermal barrier abnormality as the key driver of pathogenesis by Dr. Elias and others. The second, now let us go into the immunological dysregulation. Immunological dysregulation, there are two components. In acute stage, there are 3 cells, Th2, Th22, Th17 activated. In chronic stage, in addition to Th2, Th17 also in chronic stage, to TH. One is there is a partial switching to TH1 in chronic atopic dermatitis. So atopic dermatitis is not a purely TH1 disease. There are multiple T cell subsets are involved. So this is our latest understanding. You have got several components working on that keratinocyte, and the keratinocyte itself releases certain cytokines which promote or which switch on the TH2 cells. So you have got this is now that there are enough material to say now that all these atopic diseases are basically diseases of the epithelium. So epithelium derived cytokines play a role in promoting TH2 cells, which are the key cells that mediate what is called type 2 inflammation now. And latest addition is this fine particulate matter. These fine particulate matters are ones which are less than 2.5 micromillimeter, and they are all very the focus is on these fine particulate matters. That is why some of the I think in ISPD, Dr. Deepak used to mention about thin dress, thin full covering, I mean the full sleeved dress for all these patients. This is because this fine particulate matter, especially in cities, may have got a role, especially those who are living in the seashore, near the seashore. Atopic dermatitis get worsened because from the sea salt, this fine particulate matter might come out. And another thing is about the innate lymphoid cells, which are another key players, which are another innate cells. So epidermis, then innate lymphoid cells, then TH2 cells come in the picture. A little bit detail about the TH2 dominant or type 2 inflammation. Please remember that there are two cytokines produced by the TH2 cells. One is IL4, another one is IL13. It is very important that IL4, we have got a target. IL4 and IL13 commonly goes through a receptor, and we block that receptor by this interferon IL4 alpha receptor by dupilumab. So we are able to block the action of both. But it is very important that IL13 is emerging as the most important cytokine in atopic dermatitis because it is seen in all cases, whereas IL4 is noticed only in 40% of the biopsy lesions. IL13 can be seen in all stages, and it is more in chronic atopic dermatitis than acute, whereas IL4 and IL4 receptor, the levels remain same in acute and chronic atopic dermatitis, as has been brought out by these researchers. And it's very interesting, the same TH2 cells, when they are acted upon by the staphylococcus, become cells which produce interleukin 31, which is a very important cytokine which causes epidermal hyperinnervation of the, increased epidermal intraepidermal density. So let us put it this way. There are two components in type 2 inflammation. One is this B cell help and production of IgE. Too long we have been focused only on this IgE. Still today, we do not know how IgE is going to help in the immune response. It may play a role in antigen, presenting the antigens or allergens, but the mechanism is not fully elucidated. But the TH2 cells directly produce TH2 and T5 cells. They directly produce interleukin 4 and 13, which has got a impact on the epidermal differentiation and epidermal barrier formation. Please remember that atopic dermatitis is not simply a disease of the epidermal barrier. It is also a disease of the epidermal differentiation. That is what is called a notch signaling. The notch signaling is important for the basal cells to become stratum spinosum. This notch signaling is not functioning in atopic dermatitis. So in atopic dermatitis, there are more number of basal cells than stratum cells of the stratum spinosum or cells of stratum granulosum or cornea. So the basal to suprabasal transition itself is affected, and at suprabasal level, the tight you have got the stratum granulosum level, tight junction is affected, and then stratum corneum level you have got the lipids are affected, cornified envelope is also affected, then filaggrin is also affected, natural moisturizing factors is also affected, all by the actions of these type 2 cytokines. So they have an impact on every aspect of the epidermal structure, differentiation and barrier. So Another thing is this cutaneous microbiosis. There is the to tell you briefly, the cutaneous microbial diversity is very much reduced in atopic dermatitis. Rather, Staphylococcus aureus becomes the major pathogen. In fact, in the earlier life, in the newborn to stage, I mean, in the infantile stage, coagulous negative Staphylococcus gets established in the skin and prevents Staphylococcus aureus from gaining prominence. But this is not happening in atopic dermatitis. That is maybe because of the Th2 environment. Certainly, antimicrobial proteins are not always reduced in atopic dermatitis. Earlier, we thought Staphylococcus overgrowth is only because of antimicrobial protein deficiency, but it has been found by many papers that atopic patients do produce antimicrobial proteins, and not in all papers it has been found. I mean that the deficiency is proved in all, not in all the brought out in all the papers. Some of the papers say that the antimicrobial axis is very intact in atopic dermatitis. So the reason is the Th cytokines make the Staphylococcus adhere more to the skin by producing the adhesins. So much more about this Th2 type 2 inflammation atopic dermatitis. A word about atopy. Please remember, atopy is a predisposition. A predisposition or a tendency to develop IgE antibody. This tendency can be either familial or personal. So there are 5 components in atopic definition. There is either a personal or familial tendency. Second one is the disposition. Third one is production of IgE antibodies. Fourth one is to common allergens. Fifth one is to ordinary doses. So common environmental allergens are present everywhere. These people, they produce IgE antibody. So please remember, it will take certain time to produce IgE antibodies. So it is a last antibody to be produced in the body in an infant. So many infants may not have IgE sensitization. They may develop it later. So even otherwise also, but even otherwise also 20% of patients do not develop IgE. They come under what is called intrinsic atopic dermatitis. In fact, they have got more of other cells such as Th17 cell which is activated. Metal allergy is more common in intrinsic atopic dermatitis. So please remember that many infants do not show IgE sensitization. They may develop IgE. You have to know that the atopy is a predisposition and it will take time to manifest. IgE, if you take IgE is not always due to allergen-induced IgE. IgE can be a microbial IgE. I told you staphylococcal overgrowth is there. A person can produce IgE to all the staphylococcal superantigens. And IgE can be due to malassezia also. IgE can be due to cross-reactivity between magnesium superoxide, which is present in the aspergillus and as well as in the skin also. So that can be cross reaction to some antigen which is present in a commensal organism like malassezia or aspergillus, and then it can cross react with some human protein. So this is called autoreactivity. Please remember, I cannot rule out the role of IgE in all the cases because atopic patch test is positive mostly in those who show IgE reactivity. So atopic patch test is IgE dependent but cell mediated. So IgE does have a role in the pathogenesis of atopic dermatitis. Maybe it helps in antigen presentation, but we are not still able to fully elucidate its role. So pathogenesis is food allergy is due to systemic Th2 activation as well as the epidermal barrier, intestinal epidermal barrier permeability disturbed due to tight junction other defects. All of you know that epicutaneous entry of an allergen will stimulate allergy or Th2 sensitization, whereas the same food allergen, if it is taken by mouth, it will produce tolerance. So the gastrointestinal system is actually for inducing tolerance. So early introduction of food, especially in children who do not have perioral, before they develop this perioral excoriation, this eczema, will prevent the development of food allergy. That's a very important point that we should take up. So this is the pathogenesis of AD march. Atopic march is not fully fully explained. Just like food allergy due to systemic TH2 activation, but here it's very interesting. The TH2 activation prevents the ideally interleukin 17 mediated immune response. Interleukin 17 is a very important cytokine which is present in all the epithelium tissue. It guards the epithelium. So these TH2 cells prevent interleukins. They are mutually antagonistic. So if you look at it, TH2 and TH17 are mutually antagonistic. TH17 will upregulate the antimicrobial proteins. That is not happening in atopic dermatitis because the powerful cell is a TH2 cell in atopic dermatitis. It dominates the immune milieu. So because of that, the epithelial integrity is also damaged in the lung. That is one of the reasons the child may develop allergic asthma and allergic rhinitis, in addition to the systemic TH2 activation. So please remember, there are multiple T cell subsets are involved. TH17, which are seen in acute, and the same in chronic also. TH22 cells are very important cells. They are responsible for the epidermal hyperplasia. Many older children, older adults, you will have lichenification. The lichenification is mainly because epidermal hyperplasia due to TH22. So it is another important protein that also upregulates certain inflammatory proteins in the skin. Recently, a lot of work has been done on the endotypes. It has been found that filaggrin synthesis is preserved in infants less than 6 months of age. So and TH17 response develops very early in life, but TH22 takes much more time and TH1 takes much more time. TH1 activity is not seen in infants. This has been found out by many works done on the transcriptome and immunohistology. So it goes in this way. Earlier it is a TH2 activation, TH17 activation, then TH22, then TH1 probably, and TH9 cells also play a role in children, which is also another type of cell in children. So 5 types of T cells are involved, and the regulatory cells do not function well in atopic dermatitis. So all the 6 cells are involved in atopic dermatitis in different proportions. So much so about, let me come to the last topic, the pruritus in atopic dermatitis. I think I will have 3 more minutes. Please remember that this, I already highlighted you about interleukin 31, which is a cytokine produced by the T cells and the epidermal cells, which works on the nerves. The central feature in atopic dermatitis is the inflammation results in production of nerve elongation factors, especially eosinophils and mast cells, which get accumulated there, produce that nerve elongation factors, and the nerve repulsion factors are legs. So I told you the nerve fibers normally have difficulty in crossing the basement membrane, but now under the influence of these nerve elongation factors, the dermis can produce more of matrix metalloproteinases, which can penetrate the basement membrane, and they will cross the stratum granulosum tight junction. Normally they are below the tight junction. They cross the stratum corneum and they are in stratum corneum. That is why there is increase in nerve fiber itching. There is this hyperness is because of this increased intra nerve fiber density. And nerve repulsion factors are reduced. But if you carefully go through this, the nerve growth factor is produced in the epidermis. It goes and acts in the nerves. Nerves produce neuropeptide. And the nerve and the epidermis cells are almost the same. All the cytokines which are proteins produced by the nerves can be produced by the epidermal cells also. But somehow it does not allow that. I think that is why the epidermis is not allowing the nerves to grow in normal skin. So Josipovic, who has done a lot of work on pruritus, found that the keratinocyte is as good as a neural cell. So these neuropeptides produced in the nerves, and they go and act on the mast cells. Mast cell releases the enzymes. Enzymes will once again act on the nerve, and the nerve ending. Nerve endings once again release neuropeptides. They go and act on the epidermis, produce neuropeptides from the epidermis. So it's a vicious cycle of itch sensitization and scratching and damage. So in chronic AD, intraepidermal nerve density is reduced. So this is the last slide. Please look at the itch pathway. There are so many cytokines involved. There are so many proteases involved. There are so many neuropeptides are involved, and periostin, another very important substance which is produced by the fibroblast. So please, we have to be very careful, understand the pathogenesis in fully. So fibroblasts have got a role. So that is why I think most of the time we overuse the tacrolimus instead of topical steroids. Tacrolimus has got minimum effect on the fibroblasts. I'm sorry for talking about, going out of this topic. So fibroblasts have got a role in the immunopathy, produce a protein called periostin. So this itching, it goes on. Please look at it. The cingulate cortex is the area where the entire, whatever the entire body is represented. So motor coordination, whatever the action is planned, that is the place where sensation becomes and cognition. So every sensation is appreciated in the cingulate cortex, and subsequently it goes to the medial parietal cortex. So any person, this non-histamic itch in atopic dermatitis goes to the medial parietal cortex. Medial parietal cortex, there's a nucleus called precuneus, and anything that goes to nucleus will become permanently ingrained in the memory of the individuals. So any unpleasant experience will be remembered by our medial parietal cortex. So in atopic dermatitis, which reaches the medial parietal cortex called precuneus, the person will throughout life, whenever he has got a bad experience, he will remember, recollect the itch episodes in his childhood, and this will further affect, have an impact on his personality. And insula is the area wherever the internal sensation, for example, you have got a pleasant drink, that is, you have a pleasant feeling, this internal feeling is recognized in the insula. So their coordination between the motor activities, coordination between emotional activities and emotional feelings, coordination between the autonomic immune signals, everything is appreciated in the insula. Insula is this area which is submerged in the lateral sulcus. So atopic dermatitis itch travels to insula, and finally it goes to dorsolateral prefrontal cortex, where this aversion or acceptance is decided. Once it is aversive stimuli, then our body looks for some way to make it pleasant. That is why you have got this hedonic urge to scratch. In normal person, if there is no itch, if they scratch the skin, they will get pain. They will have an unpleasant feeling. Whereas in atopic dermatitis, even if they don't have the, I'm talking about chronic patients who are not treated, even if they do not have a urge to itch also, if they scratch the skin, they get a pleasant feeling, because this itching activates amygdala, claustrum, and basal ganglia, which have got powerful reward circuits. So that the feeling of pleasantness due to this, an unpleasant situation is converted into a pleasant situation because of these reward circuits. So it's our duty to treat atopic dermatitis as early as possible and do not allow this cycle to progress further. Thank you. Thank you. Sir, can I ask the questions now?
Okay, you go ahead.
Yeah. That's the first question. Half-life of IgE when complex with its receptor is: A is 2 days, B is 21 days, C is 10 days, D 34 days. Please choose one option.
Please post it in the chat box. 60 seconds time.
Hello.
Doctors, please post it in the chat box, your answers. 60 seconds time.
Within, or shall I will tell you again, sir, once the questions are over.
Sir, I will tell, sir. Just to give us a moment. Yes, sir.
Yes. You do it.
Yes, sir. Yes, sir.
Okay.
I'm up, sir. Second question. Yes, sir.
Second question. So, which cytokine is most consistently expressed in the skin of individuals who are affected with atopic dermatitis? So, which is the cytokine which is most consistently expressed in the skin of individuals affected with the atopic dermatitis? Interleukin 4 A, interleukin 13 B, interleukin 5 3, Interleukin 22D. Please choose one option.
Sir, time up, sir.
Okay.
Next
Yes, sir.
question.
Okay. I'll go to the next question. Tight junctions are formed by cells of which layer of skin? Tight junctions. Stratum granulosum 1, stratum granulosum 1 and 2 together. Stratum granulosum SG2. D is stratum granulosum SG3. Please choose the right option, correct option.
Time up, sir. You can shoot, sir. Last question.
So this is the last question, maybe somewhat difficult. I have given 4 statements here. Please choose the incorrect statement. Which of the following statements is not correct? A. Loss of function mutation in the Filaggrin gene is the strongest known genetic risk factor for developing Atopic Dermatitis. B. Site-specific diversity of microbiome in healthy skin is noticeable from day 2 of life. C. Contact allergy to metal is a feature of extrinsic atopic dermatitis. D. Dermcidin is a anionic antimicrobial protein found in humans. See, find out which is the incorrect statement.
Sir, time up, sir.
Okay.
Time up, sir.
Okay. So I will read the answer, sir. 1 minute.
Yes, sir.
Okay, that is the first question. Half-life of IgE when complex with this receptor. This is very important to remember because IgE is the hemoglobin living for the shortest period of time. It is there only for 2 days. Half-life is just for 2 days. I mean, 50% of them, the lowest level is IgE, and 50% of them goes down in 2 days. But here, I asked you half-life of IgE, which is complex with the receptors. So there it stays, tissue IgE stays for 21 levels. Problem is we measure only the blood IgE. We don't know what is the tissue IgE. In some, in rhinitis and all, they have done a lot of studies on nasal biopsies and found that IgE lives for longer in the tissue. Okay, the answer is B, which is, I have already told you in the talk, which is the most consistently expressed cytokine. I told you IL-4 is seen only in 40% of the biopsies. So IL-13 is the answer. And IL-5 is from the eosinophils. I mean, it's working on the eosinophils. IL-22, it is variable. In some, it can be less in mild, lesser, it's less in African Americans when compared to us. So it is, it's a variable. IL-17, IL-22 are all variable. So answer is B. Tight junctions. I think SG2, I have shown you the diagram, the apical surface and lateral surface of SG2. So it is formed by SG2. There are 3 layers. So SG2. Which of the following statements is not correct? Here, I know the A is not correct. A is correct. Filaggrin, I have told you. 2 is also site-specific diversity. Third one, it's very important that there are 2 types of, it is for theoretical basis, extrinsic and intrinsic atopic dermatitis. I told you 80% of them only develop IgE, 20% do not develop IgE. And for them, it has been found that they have got more of, the Th2 activation is not that much powerful in them. They develop allergy to nickel, which is much more common in intrinsic atopic dermatitis. Metal allergy is much more common in nickel, especially in intrinsic. And dermcidin is very interesting. It is the only anionic antimicrobial protein. Most of them are cationic. So I thank all of you who participated in the quiz. Thank you, sir. Let me stop sharing.
Okay, thank you, Dr.
Did we-
Ramote. Come on.
Hope it is enjoyable, sir.
Naveen, you want to say
Yes, sir.
something? Yeah.
Yes, sir. Sir, Dr. OMC, name is not mentioned. Dr. OMC is the first question winner. His name and the doctor first question. Doctor, shall I announce the winners now? Because we are
Yeah.
not getting there.
Oh,
Yes. The first question winner is in the name mentioned, it is OMC. Dr. OMC, I mean, doctor name. In the
Please.
list, it is showing.
Please tell.
Hello? OMC. Doctor, if your voice is not audible, means please put it in the chat box. And the second question winner is Xiaomi. The mobile only name only shows Xiaomi. And the third question is Haikul. Haikul, name is Haikul. Fourth question is Dr. Rajesh Rajagopalan. Dr. Rajesh Rajagopalan. Fourth question, Dr. Rajesh Rajagopalan. Sir,
Yes, sir.
Doctor,
Yes, yes, sir.
Hi, Rajesh.
Yes, sir.
Hi,
Sir, you are from, sir?
I am from Erode.
He's the most popular person in Europe.
Okay, sir. Okay, fine, sir. Fine, sir. Okay, sir. These doctors, Dr. OMC, Dr. Xiaomi, and Haikul, doctors are requested to post their name and mobile number and institution in the chat box. Yes, doctor, I got it. Dr. OMC, Dr. Bharati. Doctor, you're from, doctor? Okay, I got it. Thank you, doctor. Thank you so much. And Dr. I mean, Xiaomi, second question winner. Xiaomi. Okay, Osmania. Thank you, doctor. You can proceed second one. Credence, sir. You can proceed. Thank you, sir.
Should I share the screen?
Yes, sir.
Um,
Before that, Credence, sir will tell, sir.
Okay, there's nothing much to be talked. Dr. Ramamurthy had given an overview of Etiopathogenesis. Now we are going to hear from Ram Gulati about clinical features. And the clinical features are very important, as when you see the patient, the clinical features make you to make a diagnosis. And this is very important to understand the clinical features in the context of Etiopathogenesis, and then we can formulate the treatment. So I request Dr. Ram, go ahead with your presentation.
Right. Thank you. Right. Good afternoon, everybody. So, atopic dermatitis, I think we had a wonderful talk by Dr. Ramamurthy describing the etiopathogenesis of atopic dermatitis. And I think once we have heard the etiopathogenesis, we can definitely make one thing is particularly sure that atopic dermatitis is it's not a simple condition. It's a complex condition, and there are multiple areas of etiopathogenesis which probably just come together and give you these different phenotypes with which the patients present. So the objective here is to give you an overview of some typical clinical manifestations, some atypical clinical manifestations, do diagnostic criteria do justice to coming to a conclusion? Can laboratory help? Though Dr. Ramamurthy has given us a bit of a glimpse into the role of IgE, I'll probably touch upon maybe just a couple of slides on food allergy, and then we'll have the quiz. So clinical manifestations, by itself, if we see clinical manifestations, sometimes we come across a bookish case where you see just the cheek involvement in an infant, or you come across with very typical flexural involvement in an adolescent. But then most of these children that we see, the book is nowhere to be seen. So you've got a huge variability in clinical manifestation, and then coming to a conclusion whether we are dealing with atopic dermatitis. So we see a difference in clinical manifestations as the age progresses. So we see that the cheeks are probably, or the face is probably the first area, and Dr. Ramamurthy said it is the area where the stratum corneum is the thinnest. So it is the face and then the flexure. Definitely, they are one of the commonest areas as well. So chronologically, you will see that the cheeks are involved first, and then the child progresses to the infantile age group. There is a phase when the toddler starts crawling, and you see the involvement of the extensors, and then beyond the infantile phase, when you go into the childhood phase beyond 2.5 years, one starts seeing the flexural component and then the periorbital involvement area as well. And then if we talk a little about the senile eczema that we see beyond 60 years of age, the presentation is quite different as compared to the initial parts of the eczema. The clinical manifestation would vary if you come across a child who has got an acute eczematous process as compared to a chronic eczematous process. And you see in that acute eczema, you will present as a quite inflamed area, which may have microvesiculation, oozing, micropapulation. So a lot of edema there. Whereas chronic eczema, you will see a thick lichenified areas where you will see the stratum corneum has thickened because of probably the constant rubbing. So the clinical manifestations would vary depending upon how the child presents or the adult presents. Then, as I've already told, the chronological age-related changes that you see on the skin are quite a typical atopic eczema, but there are a lot of atypical manifestations as well. And probably if one goes through the Hanifin and Rajka's criteria 1980, the minor criteria probably cover most of these atypical presentations. And these presentations are something which will not have, they will not fulfill the full criteria for atopic eczema if we go through various diagnostic criteria. And therefore, they need to be seen with a different eye. Again, you may have a mild eczema, the moderate eczema, and severe eczema. You will see different clinical manifestations. There has been a kind of a rhetoric where early onset versus late onset. So you've got early onset eczema, which is bound to be a bit more severe as compared to the late onset eczema. Whether you have got a Filaggrin deficiency or not, that again has a role to play. Dr. Ramamurthy has gone through a bit of a glimpses on intrinsic versus extrinsic eczema. Whether there is a difference in the phenotypes, there's a big question mark on it, but definitely the etiopathogenesis, there's a difference there. And then we definitely are progressing towards a phase of research where probably we'll have endotypes of atopic eczema. And for example, a Filaggrin deficiency endotype. So people who have got a Filaggrin deficiency presenting with atopic eczema have got one endotype. Maybe the people who have got a certain high cytokines, for example, maybe the TARC cytokine, they will have a different endotype. And these endotypes may progress on to something called endophenotype. So there may be a difference in the phenotype with which these endotypes present. And that is something which is probably the future will tell how far we go with these. So if we just go through some typical clinical manifestations, how a child with atopic eczema presents. And Dr. Ramamurthy said about 60% of these children are going to present within the first year and maybe 85% within the first 5 years when you look at children with atopic eczema. So the infants within the first 3 months or so, they start presenting with eczema on the cheeks. So it was McAleer who first demonstrated that the Filaggrin breakdown products in the first year of life, they are lowest in the cheek when he compared them with the elbow and the nasal tip. And he showed that these were the slowest to achieve maturity levels. And maybe that is one reason that the cheeks probably are the first to present with atopic dermatitis, apart from what we have seen that they have a thin stratum corneum. So these are very much vulnerable to external insults. So probably have got this epidermal barrier defect, which starts with the cheeks. And then as the insult from the external environment continues, you start getting this eczema widely distributed in various spaces. The napkin area is usually spared, and the adage is that probably it is a very moist area, and moisturizing probably helps in leaving this area as an excluded area from atopic dermatitis. Now, itching and dry skin, these are kind of hallmarks of atopic eczema. And if we go through various diagnostic criteria, these are kind of common words that you will see among them. With the itching, I think one has to be very wary about children who have got some physical weakness or neonates who don't have the dexterity to scratch. So itching may not present as itching, but it may present with some excoriations with a child who is just distressed. Dry scaly red with excoriations, so you've got a dry skin. Even though the UK Working Party criteria at one point was thinking of putting in dryness, but then they went on with a general history of a dry skin rather than dryness because they could not see phenotypic dryness in all of these children. So if you look at these photographs, you can see that a very ill-defined erythematous area on the cheeks. rough to touch, and you can have micropapulation, you can have microvesiculation if it's acute involvement, and excoriations. So early atopic eczema affecting the cheeks of a child. And one has to be very wary of seeing few presentations which differ from a very typical eczema. So on the left side, you can see that some yellow crusting which can be seen on the cheeks. And whenever you see a yellow crusting, what you are dealing with is a secondary infection, mostly staphylococci, which produce this yellow crusted areas. And these are the eczematous areas. If I just delve a bit into the management part, until and unless you treat the secondary infection, just the armamentarium that you have of emollients and a topical steroid may not work. So one has to be wary of these. The viral infections, definitely one has to think in terms of an eczema herpeticum. The moment you see these dotted structures within the eczematous area, which are very discrete, and the child probably would be more complaining of burning sensation and a pain rather than the itchy sensation. So many times what we do is we end up increasing the potency of the steroid. So rather than that, one has to be judgmental about dealing with eczema herpeticum. So these children will need antiviral acyclovir or the equivalent. And if you've got systemic involvement, then definitely systemic acyclovir or an oral acyclovir, which is really important rather than increasing the potency of the steroid. If you've got a facial eczema which is worsening despite an optimal treatment, as we've already looked at the previous slide, do think in terms of a secondary infection, especially bacterial infections. The viral would definitely look very different, whether it be eczema herpeticum or eczema coxsackium. But what is happening with this tinea epidemic, one has to be very sure that they are not dealing with a modified tinea on the face, and go into the family history, whether any other people in the family have got tinea infections, and be wary of fungal presenting as a steroid modified eczema. Now, contact dermatitis, one had to think of, especially to the products that you're using onto the face, and that may present with an eczema which is worsening despite your optimal treatment. And if despite all rationalization, the things are not settling, then in moderate to severe eczema, one needs to think about checking for food allergies, especially in children below 1 year of age or even up to 5 years of age. And now as the children grow, they become toddlers, they go to the preschool group. So as the crawling starts, you can see the extensors getting involved, which are localized, thickened areas. As the children become more dexterous, they can use their nails to scratch and excoriate the area. You'll see more of excoriation in this age group. And eventually from the extensor aspect, there's a gradual change to flexural areas where there's a thought process that maybe with the mobility, the antigenic components or the aeroallergens tend to actually just settle down into the flexures. And with a very thin stratum corneum, these areas become much more prone to develop eczematous processes. So you can see these eczematous areas onto the extensors, which are there maybe in an age group somewhere between 6 to 9 months to then going beyond 1.5 years, and beyond 2 years, you start seeing the flexural involvement. And here, if you see, this is area which is very excoriated because of the scratching. But apart from that, what you can visualize here is a central area which is darker than the peripheral area. So this is a lichenified area. So lichenification is that the skin becomes darker in color because of the increased thickness, and the skin markings are much more prominent. So you will see a pigmented, thick area with more prominent skin markings, which is called lichenification, which you can much more probably see in this particular photograph here behind the knee. There's a very thick lichenified area. It is pigmented in there, and you can see more skin creases. But if you see this kind of a discoid areas, one has to vary that it is not a tinea which has been modified. But you see here that there is no central clearing. The periphery does not show very typical scales. But again, that is one of the differential in areas which present like these. As the children grow, you will see more involvement of the eyelids, the earlobes, the retroauricular area. Even the retroauricular area sometimes can be seen quite early on as well. And the neck gets involved, what we term clinically as a dirty neck. So one can see the involvement of the periocular area onto the left photograph. And then there are these thickened folds that can be seen, especially below the eyelids. And these are something called Denny-Morgan lines, Denny-Morgan folds. Initially, there was probably kind of a inclination that these are because of constant rubbing, but then it was seen that these folds are seen sometimes quite early on in the age groups where the children they are not dexterous enough to actually scratch these areas. And it has been shown that there may be some dermal edema in these areas, or there is some autonomic dysregulation. So we really don't know why the Denny-Morgan folds are there, but they are something which can be a hallmark of atopic eczema, or then you can already see that there's a thinning of the lateral 1/3 of the eyebrows into the left photograph, which is known as the Hertogay sign, and that has been shown because of the constant rubbing of these areas. And once you start treating these areas with topical therapy, it has been shown that a large proportion of these children tend to gain these eyebrows back. Onto the right side, you can see a transverse nasal crease, even though not a kind of a clinical manifestation of atopic dermatitis per se. It is much more associated with allergic rhinitis because of the constant up pushing of the nose that you come across this transverse hyperpigmented line, which is called the transverse crease or the allergic salute. If I give you a glimpse of the adult atopic dermatitis, just one slide, the adult eczema is 18 to 59 years of age, and pretty much you see similar kind of an eczema as you see in an adolescent. But when you see eczema starting beyond 60 years of age, which we term as a senile eczema, you see a huge difference in the presentation. So you see that the buttocks and genitals can be quite commonly involved. The face and hands can be involved. And what very particular feature that you see in senile eczema is the reverse lichenification in the fold. That means the extensor areas are much more lichenified as compared to the folded areas, which are usually free. And there is a significant chance of these eczematous processes to go into the erythrodermic or a very chronic phase. One of the articles did say that smoking is probably a risk factor, and one can go through the article by Dr. A.J. Cover in 2016 in IJD about the adult onset atopic dermatitis. There have been a couple of articles, for example, by Summers, who in 2013 showed that the chronic eczematous eruptions which starts in these age groups, one has to be wary of the drug-induced eczematous eruptions. And they have shown that if the calcium channel blockers or thiazides are stopped, these eczematous eruptions actually settle down. So take a good drug history if you see a person presenting with eczematous processes in beyond 60 years of age. And then again, there was a publication by Hulse in 2019 where they found some non-atopic eczema in the elderly woman, and they thought that maybe the pollutants are something. So maybe the free particulate or the fine particulate matter less than 2.5 micron, as Dr. Ramamurthy was saying, may be having some kind of a role to play in these non-atopic eczema of the elderly. Atypical clinical presentations in children. So these are kind of typical that we saw, but sometimes you come across the presentations which are very atypical. That means that they're not fulfilling the criteria or diagnostic criteria that we have at hand for atopic eczema. So there's a huge list of atypical clinical presentations in children. I think if we just go through a few of them. So if we have a look at the first photograph on the left, which I'm marking with the cursor, this is something which is called a lichenoid eruption. So it almost resembles clinically lichen planus or lichenoid eruption, called the lichenoid atopic dermatitis. These are usually present in children. If you see them, it's not a common presentation, it's a rarer presentation, but you see them onto the extensor areas of the limbs. Sometimes if you it's very difficult to differentiate if they are not very lichenified. You may have to make a differentiation with dermatitis herpetiformis as well. But if they are shiny and lichenoid, sometimes you have to resort to a biopsy to see that it's a spongiotic process and not a lichenoid process. These are usually stubborn, and apart from the topical application, sometimes you have to resort to other mechanisms of treatment. The nummular type atopic dermatitis, you see the discoid variant, which is the second photograph as I'm putting the cursor on. The nummular dermatitis, even though they can be part and parcel of the atopic dermatitis, sometimes you see a nummular dermatitis, which is non-atopic as well. So they can be one of the rarer presentations. Again, they are very stubborn, seen on the trunk and the limbs of children. Sometimes even in infancy, you can see rarely. And these will need application of slightly stronger steroids topically, or maybe the calcium inhibitors. And they may need proactive treatment for a while before they settle down completely. On the buttocks, we are seeing the psoriasiform atopic dermatitis, as you can see. So these are very typical sites. The scalp and the buttocks can be the sites where you can see psoriasiform atopic dermatitis. And as Dr. Ramamurthy said, there is a TH17, TH22, and Asian population, you probably see more of psoriasiform atopic dermatitis than the rest of the world. And it is shown that TH17, TH22 has got a much more role to play in Asian population. And maybe IL-4, IL-13 is something which is constant throughout the various ethnic backgrounds. Psoriasiform atopic dermatitis again is kind of a stubborn atopic dermatitis, and you might have to resort to therapies other than the topical therapies that we have at hand. If you look at the plantar area in the fourth photograph, there's something which we would term as juvenile plantar dermatosis, and maybe a part and parcel of the atopic dermatitis. And it has been shown that it just involves the forefoot plantar area, which you will see erythema, sometimes glazed appearance, but sometimes they can be scaling. And these many a times tend to settle beyond puberty. But before that, the emollients are the mainstay of therapy, though we have to resort to topical application of steroid or calcineurin inhibitors. Nipple eczema, again, a very atypical variant of the atopic dermatitis, usually presents bilaterally, and it involves only the nipple area, largely seen in adolescents. Itchy areas, again, would need application of slightly more potent steroids or maybe calcineurin inhibitors as a proactive treatment. If unilateral, definitely you've got other differentials in place, but unusually unilateral presentation of atopic dermatitis as a nipple eczema can be seen as well. Sometimes contact reactions to what you're wearing can have a presentation similar to nipple eczema. Lip-lick dermatitis presents with dermatitic areas which are involving the lips and the perioral area. So you can see in this photograph, there is this hyperpigmentation, which is all around the mouth, along with thickening of the area of the lips. So this is something which starts as a kind of innocuous licking of the lips, maybe at the change of the season, where children start feeling somewhat dry on the lips. But the moment they start licking the lips, the urge to lick the lips actually progresses, because the saliva itself is an irritant for the outer skin. And eventually what you develop is a dermatitic area involving the lips and the perioral area up till where the tongue touches. So this one, emollients again are the mainstay, but one may have to resort to milder steroid for a short period and maybe the calcineurin inhibitors over a longer period of time. There are differentials for perioral dermatitis, but they are rarer. So most of the times, if you have an atopic background and the involvement of the lips in the perioral area, you are dealing with the lip-lick dermatitis. Again, looking at the last photograph, which has got the upper eyelid involvement or the upper eyelid dermatitis, they can be a part and parcel of the atopic eczema, and they can be because of the aeroallergens that you actually come across into the flexures. In these, if you've got a unilateral involvement, one may have to think in terms of a contact reaction, especially in adolescents who are wearing nail varnishes. Or if you've got a bilateral involvement, again, if what cosmetics you are putting onto the eyes may have a role to play, for example, the mascara or the eyeliners. So one has to be wary of contact reactions. Sometimes unilateral involvement of the eyelid has, the tinea has presented as that as well. So unilaterals, you have to think of contact reactions and fungal infections as possible etiopathogenesis or a differential. There are a number of other atypical clinical presentations in children as well. So follicular atopic eczema is something which is not easy to diagnose per se, because most of the times even the parents can't see the small follicular prominences that are present usually onto the trunk and proximal extremities. And what they present is with a child who has a dry skin and is just scratching day in and day out. And it's only with a careful examination one come across these small follicular prominences, which are the part and parcel of follicular atopic dermatitis. And the moment you actually start treating it as atopic dermatitis, you start seeing the results. Atopic dermatitis of the scalp is a rare variety. Usually scalp seborrheic dermatitis is a very important differential here. But looking at the other seborrheic sites, making sure that it is not the greasier scales of the seborrheic dermatitis, one can diagnose as atopic dermatitis of the scalp, but it's a rare presentation. Alopecia of atopic dermatitis usually is involvement of the areas just surrounding the scalp. So it is the periphery of the scalp where, because of constant scratching and rubbing, the way you see the Hertogay sign or involvement of the or thinning of the lateral 1/3 of the eyebrows, or probably a similar mechanism happens onto the scalp, and they tend to lose hair from the areas where they have been scratching badly for a long period of time. And once you start treating that atopic eczema, the alopecia tends to settle. Perianal and perineal atopic dermatitis is something which is, again, as we have already mentioned before, contradictorily, we said that napkin area is something which is quite preserved as far as the eczema is concerned. And you don't see much of eczema in these areas because of the moisture that is there. But if you are presenting with perianal and perineal dermatitis, contact reactions have to be ruled out, and one has to make sure that they do a patch testing if they think of contact reactions of products they're using in this area. Other conditions where they can have a huge differential in perianal and perineal atopic dermatitis. Psoriasis can present, seborrheic dermatitis can present, contact reactions, as I said. So one has to be wary when they see dermatitic areas in the perianal and perineal, though atopic eczema very rarely can present in these areas. Retroauricular eczema, I think we have already gone through. Raggeds of nasal orifices is another one which has been reported, and it is just a dry area around the nasal orifices that is seen. We really don't know what the etiopathogenesis of the raggeds of nasal orifices is, but it may be, again, one has to think in terms of something they are putting in these areas which is causing a contact reaction, or it is just part and parcel of the atopic eczema. Finger pat eczema is much more commonly seen in elderly age groups, where it may be because of the contact reactions, whether it's an irritant insult or an allergic insult. And usually you see the volar areas of the finger pads which become eczematous. A very typical eczematous areas is being reported in the housewives, where the left hand 3 first fingers are involved because of holding the onion or the garlic, and you get the involvement of the thumb of the right hand, where you are trying to peel the onion and garlic, and you see this very classic pattern in contact reactions. Atopic hands and feet, very rarely in children, much more commonly in adults, and you see these thick lichenified areas, especially on the hands and the feet. If you have got involvement of the dorsa of the feet, one needs to think in terms of a contact reaction to the footwear, if some temporal correlationship can be held. Hands, again, if you see the dorsa of the areas, they're involved, and it can be quite a recurring and stubborn kind of a dermatitis that presents onto the hands. And the complexity of the atopic dermatitis diagnosis can be felt when one looks at these ICD-10 codes that are used for atopic dermatitis. And I've gone through ICD-11, and they are exactly pretty much the same. So if you look at the codes, atopic dermatitis, Besnius prurigo, other atopic dermatitis, neurodermatitis, a flexural eczema has got a different code, chronic eczema, infantile intrinsic eczema, and unspecified eczema, exfoliative eczema, prurigo nodularis. So there's a huge list. So if you have got a huge list where differentiation is so much difficult, we can think of the complexity with which the various morphologic phenotypes can be diagnosed. Apart from looking at these presentations of atopic eczema by themselves, one has to also look out for associated atopic conditions when they are treating atopic eczema. So, for example, the presence of the allergic rhinitis or rhinoconjunctivitis or asthma or food allergies especially, which can present as part and parcel in these children. As I've already said, that many of the atopic eczema, the presentations can be modified because of the medications that we are using. So again, those need to be considered as well. For example, if you're getting an eczema on a particular area and is not getting sorted despite the rational treatment, contact reaction to the medication that we are already using on, especially the steroids, they can again cause the eczematous processes to worsen, or sometimes an irritant reaction to one of the moisturizers that you're using. So one has to be wary of those. Again, growth, sleep, and psychological impact is something that needs to be looked out in all these children, because they can have a bearing on the way you're going to manage atopic eczema. Coming on to the severity assessment in these children, one of the ways is to clinically just have a glimpsing assessment of severity on body surface area. So when you look at the body surface area, some people thought that maybe if you have less than 3%, it's a milder atopic eczema, and 3 to 10 is kind of a moderate, and something based on how we look at psoriasis. But if you have got a scales and a scoring system, that just objectifies. So there's a more of an objective assessment. So why do you want to make an objective assessment? If you have an objective assessment, you can base your treatments much more objectively as compared to when you're just having a cursory look. You can prognosticate. You can try to monitor and see how your treatments are working or not working. And then if you're not just looking at the way the skin looks, but how the patient feels or the family feels, that is really important as well. So we all have come across patients where we thought it's a mild atopic eczema, but the quality of life is not that good. But if you've got a very severe atopic eczema, still the family is managing well. I think there the quality of life questionnaire is very, very important. So the scoring system that we have at hand, the most common ones are the EASI, the SCORAD, and the SASAD. So the EASI is the eczema area and severity index, which can vary between 0 to 72. and you got a SASAD, which is 6 area, 6 sign atopic dermatitis from 0 to 108. So EASY and SASAD, they only look at the area of involvement and the severity of involvement. That means it is a very objective assessment as to how the skin actually presents and how much severe the eczema is. The SCORAD, or the scoring atopic dermatitis, is the only scoring system which takes into consideration the subjective symptoms as well. So those are the pruritus and the sleep. So the itching and the sleep, which has a huge bearing onto the way the patient actually feels or the family feels. Some authors are of the belief that there is quite a lot of subjectivity in those, and that probably may make the SCORAD a little bit less objective. But I think there's probably a fine balance between what we are trying to achieve by these various scoring systems. If you're looking at the quality of life questionnaires, we used to have the Dermatology Life Quality Index, or DLQI, which is kind of a very generalized life quality index for various dermatological conditions. And then you have got a quality of life index for atopic dermatitis, which is specifically aimed at AD. In infants and children, you can have very specified dermatitis quality life indexes, the IDQOL and CDLQI, because they are aiming at how the child actually feels, or what child does and what a child cannot do if he has got atopic dermatitis, and give you a fair impression of how the child is feeling. Because we know it is not only the child, it is the family which gets affected when you have got eczema. The family dermatology life quality index is something which can look at the effect of the eczema on the family per se. The risk factors for severity of atopic dermatitis. So what are the things which if present can make you feel that this eczema can lead to more severe forms? So if you've got a family history of an atopy, those children can present with a more severe atopic dermatitis. And then there are a lot of number of factors. We can't say there's kind of an all or none in them. So non-breastfed child, very early formula feeding, early or late introduction of solids. If a child has been born by cesarean section, so I think Dr. Ramamurthy was saying about the microbiome. So there is a difference in the way the child gains microbiome on the skin when they are delivered either through cesarean section or a vaginal delivery is different. And that may make a difference in susceptibility to atopic dermatitis. Whether children have got frequent GI infections in the early age, vitamin D deficiencies, again, is a big question mark, and we're still debating how much role it has to play, even though vitamin D receptor polymorphisms are seen in atopic dermatitis. So these are the ones which are presented as possible risk factors for severity of atopic dermatitis. Then it has been shown that early onset of atopic dermatitis usually presents with a more severe atopic eczema as compared to late onset. Filaggrin mutation again increases the severity. Flexural onset again has been said to probably present with a more severe eczema. Food allergy, it can increase the severity of the atopic eczema if it is contributing to children who have got moderate to severe eczema. And if you take control of the food allergies or avoid those certain foods, the eczema tends to become more manageable. So it is not the parents have to be very much advised that food allergy is not the cause for eczema. It may be an exacerbating factor. And if taken control, the eczema may become much more easily manageable as compared to what it was. Again, elevated eosinophils and high IgE has sometimes been shown as a marker for more severe eczema. And if you've got other atopic conditions, history of respiratory infections, and in adults, it's been shown that maybe tobacco use may be associated with more severe atopic dermatitis. In the Indian context, if you see that it's quite a variable country. So you can't actually compare north from south, east from west, but there are certain triggers which increase the severity of the atopic dermatitis, and heat is one of them. So if you've got a heat and humidity, that tends to increase the scratching. And atopic dermatitis many a times has been said to be an itch that rashes. So if these increase the itching, then definitely the rashes increases as well. So it increases the severity of the atopic dermatitis. Dry, cold, again, winter exacerbation is more because of the dry, cold weather that makes the skin even more drier, and therefore it reduces the integrity of the stratum corneum. In fact, all the three above factors reduces the integrity of the stratum corneum. And if in that scenario, the scratching comes in, it tends to increase the severity. Clothes, so we always say wear cotton clothes. And as Dr. Ramamurthy said, full length cotton clothes, because the less you scratch the area, the less worsening is there. coarse woolen and synthetic garments tend to worsen the atopic dermatitis. So first of all, the sweating which happens is not going to be absorbed by these clothing. And secondly, the thicker fiber tends to irritate the skin. We've seen in children who got atopic dermatitis, even the labels on the back of the neck or the side of the trousers tend to irritate that skin. So when you take those label out, silk clothing in children who have got repeated infections, sometimes skilled clothing, for example, silk socks and gloves were being worn to reduce the infection rates. Environmental house dust mite and pollen allergies, and even in adults, allergy to cockroaches. There are certain things which can exacerbate atopic dermatitis, but we really don't know the exact role of the house dust mite as such. So there are authors who advocate house dust mite prevention techniques to reduce the atopic dermatitis severity, but others think that it does not work too much. So environment allergens especially can be much more have a role to play, especially in the outside areas like the periocular eczema, where the environmental allergies may have a larger role to play. Diet, I think we'll probably have a couple of slides on food allergy, and we'll discuss that. Contact allergens I've already gone through. Secondary infection. Steroid withdrawal, again, it causes significant increase in the severity of atopic dermatitis. So if somebody has been using a higher potency steroid and they suddenly withdraw, or if they're using oral steroid, which usually is not recommended, again, sudden withdrawal can markedly increase the severity of atopic dermatitis. Emotions, again, if you go to the psychological impacts, the emotional scenarios can increase inflammatory cytokines and increase the scratching in children with atopic dermatitis. It can even be a kind of attention-seeking behavior, but the moment the scratching starts, the eczema tends to worsen. Differential diagnosis, it is a must to just include this one slide, because when you're dealing with atopic dermatitis, even though it looks like very straightforward eczema, if it is not settling down with the rationalized treatment, one has to think in terms of differential diagnosis and make sure that they're not dealing with other entities. For example, seborrheic dermatitis early on, dermatitis herpetiformis. Some contact reactions may be the irritant or the allergic contact reactions. Psoriasis, scabies, tinea. In adult age group, you can have cutaneous T-cell lymphomas. Younger age groups, Langerhans cell histiocytosis, or even the PLCs can present almost like eczema. So if something which doesn't look like a very typical eczema, or not a very typical distribution, or something which is just not settling with your rationalized procedures, then do things in terms of a differential diagnosis. Conditions like hyper-IgE syndrome, Wiskott-Aldrich syndrome, Netherton syndrome, IPEX, severe combined immune deficiency, and a variant Omen syndrome, they all can present with eczematous eruptions. So it's not just dealing with eczema in these groups, but making a fuller diagnosis. One has to look at the other clinical manifestations as well, which can combine together and then maybe lead you to a more complete diagnosis rather than just atopic dermatitis. If you just look at the diagnostic criteria and the feasibility, it was even before 1980, Hanifin and Rajka had given individual criteria, and they probably tried to combine these with the relevant material which was available at that time, and they came in with the Hanifin and Rajka's criteria in 1980. And then American Academy of Dermatology criteria is quite a later on criteria, 2014, and that tends to simplify the Hanifin and Rajka criteria. But because these are bulky criteria, UK Working Party criteria in the 1990s tried to simplify it further so that it is practically usable not only in the clinic, but for epidemiological studies as well. And that is probably something which is much more validated than the other criteria as well. There's a wonderful article by Anderson, Thyssen, and Maybach, qualitative versus quantitative atopic dermatitis criteria. So all these criteria that we are actually looking at are the qualitative criteria. That means they can define whether there's an atopic dermatitis or whether the case is not an atopic dermatitis. But as we have seen in the previous slides, it's not so easy to come across and say this is atopic dermatitis for sure. So sometimes quantitatively, if you can actually justify, that can be something good. Maybe the Deepgen criteria 1996 is the only one which actually takes into control some quantitative aspect. But again, with the quantitative ones, you may say that it is definitely an atopic dermatitis or probably an atopic dermatitis. So I think it's not an all or none phenomenon. If you look at the Hanifin and Rajka's criteria, so it has 4 basic or major criteria and then 23 minor criteria. And you need 3 in both the groups to say that this particular patient has got atopic eczema. So if you look at the major criteria, itching, typical distribution lesions, chronic or relapsing disease, and a family history, personal or personal history of atopy. So these four major criteria you will see probably repeated across the various other classification systems, and they are probably the mainstay. And you had 23 minor criteria. So I think it was a cumbersome criteria to actually follow in clinics or epidemiological studies, even though it is still widely used, but it has been validated only in 2 studies with a total of 363 patients, and they found sensitivity, a high sensitivity of around 93-96% and specificity of 78-94%. So it is a higher sensitivity and specificity, but difficult to use in everyday life. In fact, if you look at the minor criteria, you can lump them into 4 major categories. So there's a lot of emphasis on facial features. So I've already shown the Denny-Morgan folds, the infraorbital darkening, or the allergic shiners, as they are said, hypopigmented patches like pityriasis alba, pallor, erythema, lip involvement, eye involvement in the form of conjunctivitis, anterior neck folds, then can be lumped into triggers. So food intolerance, emotions, environmental factors, and skin irritants are lumped together as minor criteria. Then the complications of atopic dermatitis, so susceptibility to cutaneous infections, impaired cell-mediated immunity, the skin test reactivity, elevated IgE levels, keratoconus and anterior subcapsular cataract. So they are all lumped as complications. And then others, for example, the early age of onset, dry skin, ichthyosis, which is present in almost 20 to 50% of these children, hyperlinearity of the palms, and keratosis pilaris, which is kind of a marker of Filaggrin mutation, hand and foot dermatitis, nipple eczema, white dermographism, and perifollicular accentuation. So there's a lot in there, but they're all lumped together, and they may present as atypical manifestations of atopic eczema, as we've already seen. So one has to be wary when they're looking at these and not just say that this child does not have atopic eczema. So you have to look the child in toto and maybe take a family history as well. American Academy of Dermatology came up with a diagnostic criteria which almost resemble Hanifin and Rajka's criteria, but they also include some clinical conditions which needs to be ruled out as they mimic atopic dermatitis. So they are just simplified Hanifin and Rajka's criteria. The UK Working Party criteria in 1994, they probably tried to simplify it much more. And they said that itchy skin is a hallmark. So if you don't have an itchy skin, you can't diagnose atopic eczema. And then 3 of the following. So either there is a history of a flexural involvement, or you can see a flexural dermatitis, except if you have got children less than 18 months of age, where cheeks or extensors may be seen. There may be a personal history of other atopic conditions like asthma or hay fever. There may be a history of a generally dry skin in the last 1 year, and onset below 2 years of age. So 3 of these 5 plus an itchy skin gives you a diagnosis of atopic eczema. So they are in fact designed to be used in larger epidemiological studies as well, because they are quick to follow and save time. And they've been validated in 19 studies, even though the sensitivity in the studies have varied quite widely between 10 to 100%, and specificity is quite high, 89-99%. I think itching is the one which increases the sensitivity, and the other 5 criteria probably try to make it more specific. So there's something which is much more widely used. Adult atopic dermatitis presenting above 60 years of age, we still do not have a clinical guidance or a diagnostic criteria. And one of the Italian groups or multiple groups coming together in 2020 have tried optimizing a clinical guidance for diagnosis of atopic dermatitis in adults, and one can go through this article regarding the same. How much the laboratory can help. So the biomarker, do we have any biomarkers for atopic dermatitis? I think IgE and Filaggrin mutation, whether we cannot take them. For IgE, for example, Dr. Ramamurthy already said 20% of the people who have been designated as intrinsic atopic dermatitis do not have a high IgE hyperreactivity. Filaggrin mutation, even in 40% of the ethnicities which have Filaggrin mutation, much more do not have those. As in fact, in the Asian population, it has been shown to be even much less prevalent. You cannot put that as a biomarker because it is absent from many of the patients. But it has been shown that if you've got a high IgE and a Filaggrin mutation, it may be a marker of increased susceptibility to development of food allergy. And similarly, if you look at the TARC, it has been shown that it may be a marker of having a more severe atopic dermatitis manifestation or a phenotype as compared to if you don't have an increase in the TARC. But we yet have to wait for a biomarker So what exactly is a biomarker? A biomarker is not just a molecule. It can be a molecule. It can be some other way, for example, a radiological technique or a physiological parameter which you can follow, but it should be a valid and a reliable marker which should be present in all cases of the particular condition. And then if you follow that marker, you should be able to base your treatment and see the changes in the biomarker. So we still are waiting for a biomarker. Histopathology can show you spongiotic dermatitis and maybe differentiate between acute and chronic processes. And maybe if you can look at a bit of an eosinophils, but it cannot differentiate between various eczematous processes. So it can definitely differentiate from other differential diagnosis if you have had hand. Food allergy and atopic dermatitis, just a few slides, and probably I'm going to end there. You don't have to look at a food allergy in all patients routinely. So you have to test for food allergy in children with atopic dermatitis who have moderate to severe eczema. It has been shown about 25 to 30% of the moderate to severe eczema have IgE-based food allergies. So here the testing or the lab can help. If you have got a history of immediate reaction or a persistent eczema despite optimized treatment, you check for food allergy. The food allergy can be IgE-based or non-IgE-based. IgE, the history is very, very important. Non-IgE, the positive predictive value of history is very low because it is very difficult to establish a cause and effect relationship. Usually it's a delayed exacerbation, which can be a few hours to a few days. The only way you can probably deal with these is have an elimination of the suspected food article for 6 to 8 weeks under a nutritional guidance. The diagnosis of food allergy, specific IgEs can be looked at for IgE-based reaction, but it has been shown that both this as well as the skin prick testing have got a much better negative predictive value than a positive predictive value. That means if you have got a negative specific IgE or a skin prick test, you can be very much sure that this particular food is not responsible for exacerbation. But if it is positive, then you have to corroborate with the history and see whether that is really of value or not. Atopic patch test was touched by Dr. Ramamurthy, but the predictive value present is unclear because we don't have a validated atopic patch test. The gold standard for atopic for food allergy is a double-blind placebo-controlled food challenge. It's very difficult in children, and most of the time we end up with a single-blinded challenge. Elimination diet for non-IgE based food allergies, they should never be done empirically, even though the NICE guidelines said that if you have got an eczema which is not settling despite the rationalized treatment, you can take away the milk for 4 to 6 weeks and see, but that should be done under a nutritional guidance. If you are doing it empirically, the child may lead to nutritional deficiency and may affect growth and development. And in fact, in adolescents, if empirically certain things are taken out of the diet, they become kind of an outcast sometimes in societies and schools and may lead to social isolation. And if you take it out empirically for a longer period of time and then suddenly reintroduce it, the child may lose tolerance and it may cause anaphylactic reaction. So these have to be taken care of. 90% of the food allergies are because of cow's milk, egg, soya, wheat, nut, and fish. In our scenarios, I think the nut and fish is less common, but the other ones are very common. Cross reactivity can happen and multiple allergies can be seen. And in these children who have got a food allergy, they should be reassessed after 12 to 18 months to see if they have grown out of the allergy. And because 1/3 are going to grow out by 1 to 3 years. And most of the time, the clinical reactivity outgrows quicker than the serum reactivity. So in summary, what I would say that atopic dermatitis can have a varied clinical presentation. So you may have a very typical presentation, which is very easy to see, and maybe you can just see the book picture there, but you can have atypical presentations, especially when you look at those minor criteria list for the Hanifin and Rajkas, which still is very useful. There are various scoring methods which are available for assessing severity of AD, but usually most of these are actually used in studies, and in clinics, it is very difficult to actually probably apply them. Maybe UK Working Party criteria is a smaller one. The diagnosis of atopic dermatitis is largely clinical. Even if you look at all the diagnostic criteria, much of it is just clinical based, and we still don't have a validated biomarker which can be used for following up these patients with atopic dermatitis. Now, children with moderate to severe atopic dermatitis, they may need testing for concomitant food allergy, but do not test for food allergy in all the patients routinely. So, thank you.
It's wonderful, Dr. Ram.
Yes, sir.
I think you can go ahead with the cues.
Sure. So I'll just go with the first question. So in the first year of life, which area of the body has been shown to have the lowest filaggrin breakdown products? So first is elbow, second is nasal tip, third is cheeks, and the fourth is all of the above.
Sir, time up, sir. Next question.
So the second one is, which of the following scoring systems for atopic eczema takes subjective symptoms into consideration? The first is SCORAD, second is EASY, third is SASAD, and the fourth is none of the above.
Next question, doctor.
Sure. The third one is, which of the following is not a minor feature in Hanifin and Rajka's criteria for atopic dermatitis? So which one is not a feature? Raised serum IgE, second is pityriasis alba, third is recurrent blepharitis, fourth is food intolerance.
Next question, please, doctor.
Yeah. The fourth one is, which of these sentences is not true? That means which of it is false. So first, skin prick test is used to test IgE-based reactions. Second is atopic patch test is not validated for testing for food allergy. Third is skin prick test for food allergies has a high negative predictive value. And fourth is children with atopic dermatitis should be routinely tested for food allergy.
Time up, sir.
Do you want me to go with the answers?
Yeah, go ahead.
Yeah, now you can go with the answers, sir.
Right. I think the first year of life, this was probably my first slide, which said that the filaggrin breakdown products are the natural moisturizing products that you see the NMFs. So it was the cheeks. The answer is number third, cheeks. So cheeks have been shown to have the lowest filaggrin breakdown products and probably the thinner skin, and that makes it susceptible as the first area to get involved in children. So answer is 3, cheeks. The second one, we have already seen that SCORAD, the EASY and the SASAD, the 2 and 3, they both actually look at only the objective, they only have an objective consideration of looking at the skin. So they look at the extent of involvement and the intensity of involvement. But SCORAD, number 1, the answer is 1, SCORAD. So the SCORAD is the only one which takes into consideration subjective symptoms, that is itching and sleep. So the answer is 1, SCORAD. The third one, which of this is not a minor feature? So it is recurrent blepharitis. Number third is the answer. So recurrent conjunctivitis is a minor feature in Hanifin and Rajka's, but recurrent blepharitis is not there. All the other three are part and parcel of Hanifin and Rajka's criteria. And the last one, which is not true. So we have seen the skin prick test. We know that both this and the IgE, they are testing for the IgE based reactions. Atopic patch test, we have gone through that it is not validated for testing of food allergy. Again, skin prick testing and the IgE testing, we have shown that they have got a very high negative predictive value, but they don't have a positive predictive value, very low. The fourth one, the answer is number 4, which is false. So the children with atopic dermatitis, they should never be routinely tested for food allergy. As we have seen, it's only 25 to 30% of the moderate to severe eczema who have got an associated food reactions, and they should only be tested when you have rationalized the treatment and they are not coming under control, then check for it. So the answer is number 4.
Thank you, Dr. Ram. It is a really nice presentation, and I think all of the postgraduates are benefited out of this presentation. We will nothing more to add to what you both of you have told. From my side, it's wonderful to hear both of you. Anyway, now over to Naveen. Naveen is there?
Yes, sir. Yes, sir. I'm here, sir. Sir, Doctor. First, for the first 3 questions, the winner is Dr. Pavitra. Dr. Pavitra. Doctor, are you there, Doctor?
Yes.
Doctor, kindly, congrats, Doctor. First of all, congrats from the committee side.
Thank you.
Yes, Doctor. Doctor, kindly put your details, Doctor, your mobile number and the institution name, Doctor, so that it is
Sure.
easy, and also your full name, so that for a certificate preparation. And the last question winner is Dr. Chinmayi Yadav. Doctor, are you there, Doctor? Dr. Chinmayi Yadav, are you there?
Yes, sir.
Ma'am, kindly put your name, full name for certificate purpose, ma'am, for mobile number and institution name, ma'am, to hand over. Thank you, ma'am.